Hello, hi. Welcome to OBHealthy, the Doctor's Lounge. And we're a group of Black physicians, and we're here for two major reasons. Number one is to improve the health of people of African descent. And number two is to encourage young Black males to go into medicine because it's so important. We need Black doctors out there, especially Black male doctors, which there's a shortage. So, welcome everyone. Our topic today is orthopedics, orthopedic medicine, and we have the perfect person to cover it from A to Z. So we're going to get into that in a minute. Remember, our webinar is every second Saturday at 1 o'clock. All righty, and those of you who are on right now, you understand you just go to OB Healthy and tap the doctor's tab and come in and you can ask your medical questions. Now, the most important thing is don't be shy about your questions. If you have a question, just type it in. We're here to answer your questions. That is truly our purpose. Our prior webinars, you have to go to the website, and on the website, you will see our YouTube channel, or on the doctor's page, you will see a little camera. Just click that. All of our prior webinars will come up, and so many topics that are important. Okay. Please subscribe when you come to that YouTube channel so that we can continue to bring it to you in that way. The most important thing I should say is please do not change any aspect of your medical care until you consult your doctor. Only your personal physician can truly take care of you from a medical standpoint. All righty. I think I've covered everything. And again, I'm going to say we have the perfect person to talk about orthopedics. But before that, I'd like Dr. Sprock to introduce himself and understand the doctors out there. They'll be coming in as time goes on. So we'll get more docs coming in and we'll introduce them as they come into the webinar. Dr. Sprock, can you introduce yourself, please?
I'm Kendall Sprout, graduate of Morehouse College, undergrad in New Jersey Medical School, which is now part of Rutgers for medicine. I'm board certified in pediatrics and retired. I did 15 years of critical care pediatrics and then the remainder of general pediatrics.
Excellent, excellent. And I'm Dr. Omar Bey, pulmonary critical care. I've retired from that aspect, but now I've always had a subspecialty in nutrition. I do nutrition now, and just so happy to be able to bring this webinar to you. All righty. Dr. James Lee, he is one of our crew here, and he's stepped up and said he's going to talk about his specialty. James, could you introduce yourself, but even more? Can you give us, why you went into medicine, how you got into medicine, and where you are right now with all of your patients? Just give us an idea of what your life is like.
Oh, sure. Thank you, Omar. I'm glad to be here. Dr. James Lee Jr. I'm a second generation orthopedic surgeon. I'm board certified. I have a fellowship in sports medicine. It's my 17th year in practice. I can't believe it went that fast, and it certainly pales in comparison to the doctors on the panel, but I'm slowly following along their footsteps. Currently, I'm a part of a private practice that spans in Paramus as well as Parsippany, New Jersey, called Modern Orthopedics. And I specialize in sports medicine, joint replacement, and fracture care. I hope you obtain good information, ask questions, and what I talk about in orthopedics is useful to you. My first exposure was as a young man. My father, Dr. James Lee Sr., is a prominent orthopedic surgeon in New Jersey, a pioneer in sports medicine from the 1970s up until now. He's 85 years young and recently retired at the age of 82. So when I was young child, my father would take me to his office hours and as well as the operating room, the hospital. Before there was a lot of regulations, well before COVID, we had a little more leeway with what we could do in the operating room, and I was able to observe surgeries. But I think most importantly, what I observed was the relationship my father had with his patients,
Hmm.
and you know, we call this bedside manner, the ability to talk to a patient, put them at ease, whether they have a difficult circumstance. That's probably the number one thing I took away, where it was my father enjoyed what he did. He was able to, be a comedian and sort of be a scientist at the same time, which is part of what we do. And, a lot of times we refer to medicine as a science and an art. And we spend a lot of time studying but the art is when you can speak to a patient and you can get them to understand, treatment that you recommend, and hopefully steer them in the right way, and so they can make, healthy choices with their life.
Excellent, excellent. Well, there orthopedics is a wow, it's a big topic.
Yeah.
And I know that you have your particular specialty as far as it's concerned. Um, just start off with general, how you would start off just introducing the subject to someone who doesn't understand it at this particular point, and then we'll get into some details.
Sure,
Hey,
sure.
Omar, could you get Dr. Court to give
Yeah,
his?
I sure will. Dr. Court, can you hear us?
Yes, I can.
For
I have
some
to turn the
reason,
TV.
we only have half of your
All right.
your picture.
Um,
I'm not sure. Half of it is black,
Block.
completely black, and I'm not sure why.
all
You
right.
you may have to sign off and sign back. There. Oh,
That's
there
much,
you
There you go.
much
there
better.
you go. I don't know why we're missing half of you because it's nice to
We
see
need
your
to
whole face.
we need the full Dr.
You should
Cord, the
want a
full
hold
Dr.
of me. Hey, guy. Hi
Hey,
there.
Dr. Cord.
Well, Dr. Court, please introduce yourself.
James Court, my specialty in internal medicine. I practice in East Orange, New Jersey.
Excellent, excellent. All righty. Dr. Lee, uh,
Yeah, so
where were we? We were going to
yeah,
rock
you
and roll
asked
here.
about introducing orthopedics, and sort of what is it. So if you go to the root word, like ortho is straight, that just means straight, and peds is child. So
Mhm.
orthopedics, the root word is straight child. I mean, that's what it means. And I think if you look at history books and what the symbolic representation of orthopedics, it's a tree that is bent with a rope tied around it with a brace and trying to straighten out the tree. And so historically, orthopedic surgeons were not actually surgeons. They were brace doctors.
Mm.
They treated mainly non-surgical. So if you did a residency, say in the 40s, 50s, and 60s, even a little bit of my father, the general surgeons were the ones who did the fracture work. And so the trauma work, where they had broken bones, the general surgeons actually treated those initially. And then over time, the field developed as it became more advanced. So initially, we treated conditions like scoliosis, which is bending of the spine, curvature, things like Blount's disease, which is severe bow legs in children, hip dysplasia or like hip instability, in children. And I would say historically, orthopedists were very good at bracing and casting. That's probably where a lot of the field started. And then as World War started and some of the war medicine evolved, where there was you had injuries, amputations, fracture, preserving bones became more scientific and evolved with World War I, World War II. You started to see more of, instead of amputating, like in the Civil War, where say a veteran is on the in the army field and is injured, amputation was very commonly used. And then as time went on, we went on to preserving bone. How do we save it? How do we prevent injuries and so forth? And now we're at a point where it's like, okay, well, how do we prevent changes in our bodies, arthritis, wear and tear, with non-surgical measures? And then with the advancements in technology, when we do have to do an operation, we're able to incorporate a lot more science and technology into what we do to try and improve our outcomes with patients. So I would say it's evolved from a non-surgical specialty to now where it is surgical, and also preservation is still a theme that we have.
Interesting, interesting. You think of it is that I'm an adult doctor, and I know that a lot of times parents are so concerned about their children
Mhm.
as far as and several things. And you had mentioned scoliosis,
Yeah.
especially what I know that I see a lot, not a lot, but sometimes you see a female with scoliosis and how you would love for them to walk up straight, but they are bent a little bit either one way or the other. What are
Right.
some of the things that can happen that can help this as far as scoliosis is concerned, especially when parents are seeing it with their children? It's a concern.
Yeah, I think it's a good question. I think part of it's screening. I was at an age when I was a elementary school student, we were screened for scoliosis. I remember going to the nurse's office and
Right.
they would check our spines, and if they screen that maybe you have a curvature, you're referred to either pediatrician or an orthopedist. And so what happens now is if the pediatrician or parent suspects that there is a deformity, and scoliosis means not only a curve, but also rotation. So the
Mhm.
spine not only bends, it actually twists. And I think what happens, Dr. Bay mentioned, like bent over. not only is the spine twisted, but the pelvis then rotates as well. That's part of it, the deformity. And where we're concerned with, say preteen who's about to go through a growth spurt, if they have a deformity, it accelerates with growth. So if they say a young female, goes through menarche, which is her first period, she tends to have a rapid growth spurt at that time. And if you have the beginnings of scoliosis or deformity, it can be accentuated and worsened. And I know in your world with, healthcare with regard to lung, we intervene. I don't do the surgery, but we intervene if we feel like their ability to breathe is compromised. Because if your
Hmm.
spine and rotates and your pelvis rotates, the ability for one lung to aerate and open and close is compromised. And so that's when surgery is oftentimes recommended. Bracing is considered and casting as well. But I think the issue is, how bad is a deformity? If I were to be a little more granular, it has to be a minimum of 10 degrees. That's the minimum. And oftentimes it's not just one plane. There could be two curves of the spine. In our neck, we talk about lordosis, which is a curvature. And then in the lumbar spine, there's also lordosis. So in order to balance our bodies when we walk, there's two curves in the spine. And when those curves change and rotate, it can often worsen. And so that's something that is very important. And, we hope that parents can pick it up, pediatricians can pick it up, maybe the school nurse, and
Hmm.
identify it early. So maybe a preventative brace or exercise program can help.
Right, right. Dr. Sprock, since we're in pediatrics, I just wanted to start with peds and then we can work into adults. Is there anything that you find, because you've done this so long, that we need to key on as far as the kids are concerned?
Yeah, the first thing is that it's important that you start this evaluation from the newborn. And one of the first things we do is we sort of look at the newborn's hips to see whether or not there's any clicks
Mhm.
when you sort of manipulate the femurs, which are the bones between the knee and the pelvis, and you see if there's a click. Now, when you think about that hip joint. Um, when babies are first born, there is no socket. When you talk about a ball and socket joint, okay? You talk about a ball and socket joint. You talk about the ball being sort of the head of the femur. You're talking about hip that fits into the socket, if you will. Um, but that doesn't happen right away. So when babies are born, that pelvic space that later will form the socket, if you will, is flat. And some babies that are born that have neuromuscular diseases and they can't walk, the way that socket develops is that when they start to walk and they're standing upright, it sort of hits into there and then that joint forms. Well, if the baby never walks, that never forms, and then that femur just sort of slides around on this flat area because the baby's not able to walk. And so it's important that you sort of do that initial examination just to look at that hip joint to see whether or not there's any abnormality in terms of how it was developed,
Right.
and you go from there. The other thing is the scoliosis examination. One of the things that is important, that the earlier you recognize that there's a curvature in the spine, the easier it is to sort of make interventions that might prevent more complicated surgeries later on.
Mhm.
And so it is important that if you sort of look at the baby's back and you look at the spine and you look at the hips, really, because that rotation that you're talking about in terms of one part of the hip being elevated higher than the other starts early. And you can imagine that if someone is walking that way, then you're going to see that they're going to walk with a limp going up and down. And just a slight correction for you, Jimmy. Menarche, which is the first period, the actual growth spurt is mostly in the first 2 years before you have the period. And then there slows a little bit later. So actually, you might have a absolutely more pronounced problem if you make the diagnosis after menarche. And so the earlier you see that there's a curvature, and it depends upon where you are in the country. In the major metropolitan areas, there are a number of pediatric orthopedic surgeons that sort of specialize in those kinds of things. And again, sometimes bracing might help early on, in terms of development, but more often than not, depending upon the degree, and they have special x-rays that they take. And just like there are pediatric orthopedic surgeons, they're pediatric radiologists.
Right.
And these pediatric radiologists will actually do the correct films, look at the various angles to see, and then make a determination as to the degree of the curvature. And again, there may be more than one curvature, and may not just be in one spot. And then the pediatric orthopedist can make a decision about what then to do and when to do it. So it is important, and like most things, a number of things that you can think about. The earlier you make the diagnosis, the better you are. I mean, things like autism and things like that. It's important that these things are screened for early enough so that you can make the interventions that might help the child develop problems much later on. School, you hit school at 6 or at 5 in kindergarten, and this day and age, there's not a whole lot of screening that goes on. A lot of things that used to be done don't get done. The pediatricians are often very busy, and some of the things that they should be doing, they aren't doing. And so it's important that if the parents think that there's a problem, they need to raise it so that then it can get checked. And then if there is an issue or concern, you can then make the referral to the person that can best handle it. And they'll make decisions about you need braces. And they're specific people that make braces that the pediatric orthopedist knows about and will direct you to if indeed you need to have it done. And sometimes you just can't go on your own to these places because you may not be getting the proper things that you need. So it is important that you kind of look at these things. Another things that people are concerned about in babies is what kind of shoes should they wear? Yeah. Back in the day, they had those little hard
shoes,
shoes, Buster Brown or whatever it was, that didn't give and wasn't very helpful with having the kids learn how to walk. And we always used to say that the best way to learn to walk is in the bare feet, so that you can look at that. And if we look for flat feet, we'd sort of create something like a paper towel or something, wet their feet and look at them, stand on it. And then you can see whether or not they actually have an arch or not. If there's no arch, it's just, everything is sort of flat. And then there's just no imprint. You don't have the typical sort of footprint that you do if you do have an arch. So those are some of the common things that we used to do in pediatrics to screen. And then if we think that there's an issue, we can then make the referral to the pediatric orthopedist.
Excellent. Dr. Lee, what's an average day in your office? What are some of the things that you just averagely see? Because I know we're going to get in specifics, but what's an average day for you?
Oh, Omar, just one little thing. Earlier on, when he was first just talking, he talked about hip dysplasia. Could you sort of explain what hip dysplasia is?
Yeah, so you mentioned that, Dr. Sprott, when you're describing it. So in order for the hip and the ball and socket to form properly, there has to be an amount of force that the femoral head creates within the socket in order to create deepening of the acetabulum or the socket. So there is a maintenance of that relationship. If the femoral head is not centered within the hip socket, then the acetabulum, which is the socket that deepens the hip joint, doesn't form, and it becomes shallow, and then it can lead to what we call like subluxation or dislocation. And that's when the femoral head, or the top, I oftentimes say it's like the scoop of ice cream, the round part at the very top of your femur bone has to be centered. And then when it is not, then you have dysplasia, and then the entire hip does not form properly. And so that, where I'll see it in my practice now with adults is I'll see it as an arthritic hip at maybe, in the late 30s, early 40s. And then when I get an x-ray, I'll see, and I'll tell the patient, look, your ball was never completely in the socket, and we call it like uncoverage, where the shelf does not cover the round part. And instead of it being all the way around, it's like here. So maybe 50% of this ball is exposed, and it just doesn't form the way and all the way. And then what happens is the forces within that hip joint are no longer uniform. And so now you're riding on one part of the bone or the other as you grow and your weight increases and you develop, and whatever you do in life, you run, jump, these joint reactive forces are no longer within the normal range. And then it creates abnormal forces. And then that cartilage that normally has distribution of force evenly no longer has that. And that leads to degenerative changes and then enzymatic degradation of the cartilage. And then eventually that, we call that arthritis, and that becomes a degenerative picture. So I think, you mentioned how critical it is. If you pick it up early enough and we're able to maintain that, child's relationship, then the hip socket can form properly, and hopefully they're not at risk of adult onset osteoarthritis from dysplasia.
Just one other thing that, I'm getting old, but you start to remember things that you forgot. One of the things that can happen, even in someone that has a normally formed hip joint, we used to see issues in individuals that had sickle cell anemia.
Oh yeah. Oh yeah.
And the folks that have sickle cell anemia sometimes have issues with the blood supply to that femoral head.
That's right.
And if they start to have a problem, maybe you can explain what happens,
Sure.
James.
So yeah, the sickle cell, so that the red blood cell does not have a normal morphology. It can't get around the blood vessels properly to create oxygenation of the surrounding tissues. And so with sickle cell anemia, in my practice, I would say more at Newark Beth Israel when the first 7 years of my career, I saw a lot of sickle cell crises, where, we'd have the inpatient crises where, there's severe pain, in the joints, in the back. And these patients are oftentimes admitted, hydrated, and given morphine and things to try and calm the pain. But to your point, my father used to use the term, the bone has a stroke. So in other words, the blood flow to that bone isn't the right way, and it doesn't get nutrition, and as a result, it can collapse. And so there's different stages of avascular necrosis or bony collapse that you mentioned. And if you're able to pick it up early enough, sometimes you can intervene and preserve that hip. There's historical procedures like you just drilling a couple of holes to get blood flow. Now there's like you can graft, with stem cells to try and get it to heal. And then when it becomes, say, advanced stage, like stage 4, when it's basically gone, then you're looking at salvage or arthroplasty reconstruction. In my practice, I tend to see these patients, towards the end or maybe in the middle stage. And it can be difficult because they tend to be on the younger side. I don't have a lot of elderly sickle cell patients. I hate to say that in terms of like life expectancy, but the ones that I tend to see in my practice are like middle age, and then the hip has collapsed. So,
And again, if there is that damage, this aseptic necrosis, you can have sepsis, an infection that causes
of
a
course,
problem. But this is without infection. The lack of oxygen does it. And again, one of the if it's not picked up is the development of arthritis, which can be
that's
very,
right.
very severe and
It
difficult
is.
to treat.
Yeah, so Omar, you mentioned like what do I see in a typical day? So if I see a younger person,
Let me just say something from a pulmonary standpoint, and many patients out there with COPD and significant asthma,
What's COPD, Omar?
chronic obstructive pulmonary disease, and most that is encompassing bronchitis, it's emphysema, it's and scarring of the lung. That can be chronic obstructive pulmonary disease. But the thing of it is that so many of these patients are treated with prednisone or steroids. And steroids, and as well as sarcoidosis. Sarcoid is one of those diseases that's fairly common in the African American community, and you treat it with steroids. And steroids can cause this aseptic necrosis of the bones as well, or the joints, I should say. Several patients throughout the years, I've seen them have this side effect of the prednisone that hip joint and bone breaks down the whole. Um, um, Formulation just breaks down because that area is not getting appropriate oxygen because of the steroids causing the aseptic necrosis. I just wanted to put that in there as well. Go ahead, James. I'm sorry.
Yeah, so you mentioned, what do I see in a typical day? In my practice, I have more of an adult practice, but I do see um, preteens, and we'll get, referred knee pain, just from overuse, activity. And, I make sure every single patient that has knee pain gets a hip exam. Dr. Sprout mentioned it, and when the baby's first born in the nursery, they do the hip exam, and that was commonly done. We did that as orthopedic residents, and we would get consultant on it. But when I have a young patient that has knee pain, there can be a thing called referred pain. And what does referred pain mean? It means that, you know, they present with the knee, say, oh, my knee hurts. It hurts right here on the side. And then what happens is there can be an upstream cause. So if there is an issue in the hip that is going on, one condition we can talk about is slip capital femoral epiphysis, and that is when the growth plate portion of the top of the femur bone slips and the femoral, the top of that bone no longer sets in place. However, that can present as knee pain. And, this child might limp into the office and say, oh, my knee hurts. And the reason why that happens is there's a nerve that travels called the obturator nerve. When that nerve is stimulated, it will signal to the body the knee is in pain. And so it can be, a devastating miss if a child has a hip issue presenting as knee pain. So I commonly will rotate their hips and, say, you're sure it's not your groin, you're sure it's not up here, and make sure we rule that out as a cause, and then we can focus on the knee. Furthermore, getting to back to my typical day, I would say the majority of my day, no, let's say 50% is arthritis. It'd be knee pain, hip pain, and then back pain. Those are the typical consultations. If I see 30 people in a day, I would venture to say approximately 5 are surgical candidates. The remaining 25 of those patients are non-surgical, and they're there for non-surgical treatment. And oftentimes a screening x-ray is done, a physical examination is done, and then education, where we're talking about, okay, you have knee pain, we rate the degree of arthritis maybe in the knee, and we present non-surgical measures. If that deteriorates over time, there are surgical options, but I would say that the majority of the patients that I see are non-surgical in nature. In addition, there are a subset of patients that are sports medicine related, where they'll come in either, what I'm seeing now is the college students have graduated or they finished their semester. They're home and they may have had a nagging injury. So I'm seeing right now, it's like lacrosse athletes come in. I have basketball players that come in and they'll say, I strained my Achilles in the season. It never really got right. I got treatment during my season with the team. However, I'm home now and I'm looking for a solution. I'll see that as well. And then as the summer goes on, you'll get the football players who want to go to camp, which starts in August. So oftentimes they'll come in for their pre-participation physical. So you'll get the athletes that want to be clear to return to play and be screened for their fall season. And then you get the ones who got hurt during school and need some type of procedure to get taken care of, and then heal during the summertime and get back on the field. So I would say that's probably my practice. You have some sports medicine, you have middle age, older age arthritic patients, and occasional preteen.
Yeah.
Dr. Lee, you raised this issue of pain and elderly individuals. There's been this big trend where these commercials come on where they're advertising stem cell injections to regenerate stuff, and now they're doing injections of gels and things like that. Could you sort of help explain whether or not it works or not, or if it does or it doesn't, why it does or why it doesn't? Because there's a lot of people making money
Right.
from all sorts of things with these stem cells, and I'm not sure where they're getting these stem cells, but certainly they're charging folks a whole lot of money, and
They
they
are.
keep have you come back for more injections.
Right.
It don't
Especially
work.
the knee.
Oh, yeah.
Gels in the knee.
Right. I agree. So I'll start with the stem cells. I had a patient I just saw who has advanced arthritis of both of her knees. 65 roughly, very active, likes to walk. A lot of pain in the front of her knee. And she went through a diagnostic journey, saw multiple physicians. I think I was her fourth opinion. But one thing she mentioned was, yeah, I got stem cells. She paid $4,000 an injection. $4,000 an injection with minimal improvement. And so that's a significant cost. Like I think it's cost prohibitive. And I would say her benefit was very, very minimal. And what I would say is the commercially available devices that harvest stem cells, based on if I were to give you the granular academic answer, we can only get 1 in 10,000 of those harvested cells to be true stem cells. Where do we get them? Bone marrow, so from the pelvis, and fat, abdominal fat. And so you can harvest this tissue, you can put it in like a centrifuge-like device, and then you can say, oh, I have stem cells. Now, what we are advised as orthopedic surgeons as the standard is say we cannot tell a patient we're going to give you stem cells because we can't harvest it. It can be done in a lab setting. Yes, they can. And when we say stem cell, the stem cell has the potential to turn into any type of cell. And in this case, we want them to make cartilage. You can make it into other tissue like bone, or heart tissue, whatever it is. It has we call it pluripotential, multiple potential to de-differentiate into other things. But the commercially available devices are very, very limited. And I think the nuance is what we're advised, and I don't do stem cells, is that we can try to induce cells to de-differentiate, but we cannot create stem cells to inject. And so if a physician is advertising they have stem cells, what I would ask as a consumer is like, well, how do I know that I'm getting a stem cell? Where are you getting it from? Are you getting it from the patient? Are you getting it from a placental? That's a very popular one too. It's placental tissue.
Well,
Harvesting.
I'm going to ask you a more difficult question.
Yes.
How truthful might that answer be from some of these folks?
I can't answer for them. I would say if they follow guidelines, they should at least advise the consumer, the patient, that it's limited in terms of true stem cells. They may induce a healing response. They may, slow down the inflammation or retard that process. But to truly say, I created new cartilage in your knee with an injection is very hard to say. I just don't know. My take with patients is, if I give them, let's say, a steroid injection, I'm decreasing the inflammation in your knee. I do platelet-rich plasma, which is different than stem cells. What that is we draw blood, we put it in a centrifuge, and we extract the healing and growth factors from the platelets. So when we get a cut, body sends blood to the area, hematoma formation happens, and inside that clot are all the growth factors, right? That's the first, response the body makes. So platelet-rich plasma retards the degradation of those enzymes in the knee by promoting healing and growth factors, but it doesn't make new cartilage. It treats the symptoms, the pain, the inflammatory reaction that happens, we call those the cytokines, interleukin 6 and tumor necrosis factor, and all those things that are degrading that knee joint. The platelet-rich plasma can slow it down, but it can necessarily stop it, and it does not make new stem cells. To get to the gel shot, the gel shot is hyaluronic acid. So hyaluronic acid is used all over the body now. It is, an
They use
analog
it
of
for the
like
skin, don't they? To
for the
make you
skin.
look young?
Yes, injections in the skin. Yeah, absolutely. The scalp. It's a rooster's comb analog. We've recreated, the properties of a rooster's comb. We've extracted what we think is a viscous syrup-like material that's injected. Now, if I were to give you the academic answer, there's no difference in outcome between a steroid shot and the gel shot. The gel shot is marketed well. People want to say, I want the gel shot. Where I would say somebody would use the gel shot versus a steroid is if they are brittle diabetic or they have like hyperglycemia. If you inject them with a steroid, I tell all my patients, if you're checking your blood sugar and I inject you with a steroid and like lidocaine mixture, expect that your blood sugar is probably going to go over 200 to 300 and will correct. But if they're, not well controlled, or maybe they're, have autoimmune compromise, you may want to reconsider not, having this steroid injection, but it's something that has to be mentioned. But if you were just looking at randomized controlled trials that compare steroid injection to gel shot, there's really no difference between the two. Last point, when somebody's bone on bone, really no use for the gel shot. It's gone. It's not really, it's meant to sort of lubricate, but once you're bone on bone, this comes up a lot. People ask me, "Oh, can I have the gel shot?" And I tell them, "I look at your X-ray. There's no space left. I'm not really sure what we're doing here." And I try to let them know.
When is the gel shot indicated?
The gel shot, I would say the best candidate is early mid-stage arthritis. So if I were to give you the like a radiographic classification, there's like 0 through 4. 4 is bone on bone. Like I do standing alignment X-rays in the office. And if they're bone on bone, we can add, like, there's no surprise. You show the patient the X-ray, there's a visual, they understand that knee is at the end stage. 1 is very little change. There's no joint space narrowing. You might see a small bone spur. 2, you could maybe surmise there's a little joint space narrowing. There's osteophytes or bone spurs surrounding the knee joint. 3 is there's significant joint space narrowing, but it's not bone on bone, and there is osteophytes around the knee joint. So I would say your early stage 1, 2, possibly 3 are your best, and it's radiographic. If it's bone on bone, it just doesn't seem to work very well.
I have a question. The stem cells, are we talking about when people say, well, I got a shot that it's going to give me cartilage, going to regrow my cartilage, or, that type of, we're talking about the stem cell there?
Yes, that's the
Mhm.
stem cell. And the point I was trying to make is the commercially available harvesting tools we have. If I take 60 milliliters of somebody's bone marrow, I can say 1 in 10,000 of those cells are going to be true stem cells. They're going to make new cartilage. So
Mhm.
that injection that we finally put in them, I have to explain to them that the probability of giving them a true stem cell is 1 in 10,000.
Yeah,
So,
I've had
so just
patients that.
just another question about that. Just because it's a stem cell, does it mean that, and it can go into almost any tissue that you name, nervous tissue, cardiac tissue, muscle
Right.
tissue, anything. Just because you put it in a location doesn't necessarily mean it's going to turn into whatever that
Agree.
location the cells
Uh,
happen to be, does
there's
it?
there's no way to know. Honestly, there's no way to know. I suppose if we really knew, like we could arthroscopically look at the knee, take a picture, a photograph, maybe do an MRI pre and post injection and see if there was a discrete cartilage missing, say a little pothole the size of a dime, and we picked that up on an MRI. We call that an osteochondral defect, OCD. If we had that a pre and then you do the stem cell and then you do a repeat MRI 6 months later and it fills in, hey, maybe you could argue that, but it is rarely done, and that's very costly. That's an expensive, way to look at it, and
Mhm.
it's difficult to sell that to a patient. If people are saying that, I would question it. I would ask the physician, like, how do you know? What data do you have to support that you're putting in a stem cell and it's actually causing
Mhm.
growth of cartilage in the spot that you want it to grow?
Right, right.
Does insurance pay for it?
No,
Mm.
no, does not.
Okay, all right. Dr. Court, you have your hand up,
So
please.
that's when I asked the doctor, when is the steroid injection indicated?
Good question.
Well,
I would say my typical patient that presents with knee pain, um, it's probably the second line treatment if they've tried maybe an anti-inflammatory, rest, ice, things like that, and they have recurrent pain and swelling in their knee. I usually tell them if Tylenol or Motrin doesn't help you and you come in the office and it's really bad, what I my line to the patient is the most aggressive thing I can do for you is give you a steroid injection. That's what I can do to help your pain go away. If it's like a dull ache and they say, Doc, it only bothers me once a month, I take my Motrin or I ice it down, I feel okay. I generally will not tell them that. If they come in, or I don't recommend the steroid injection. If they come in and it's severe pain and they say, when I get in and out of the car, every step I take, it hurts me. I go to the grocery store and, I'm really struggling with every step. Then I tend to steer them more towards a steroid injection to see if it will help them. And then I also make sure they haven't had one recently. It's not healthy to get a repeat steroid injection, repeatedly. Once you get steroid, it actually degrades the collagen and tissue. And so I wouldn't say more than 3 a year. I wouldn't recommend every 3 to 4 months at the most, for a steroid injection.
Mhm. So,
okay.
yeah, I didn't know that. You say repeated steroid injections can actually deteriorate
Absolutely.
some of the structure that's there
Absolutely
over
can.
time.
Over
And
time. Over time. Yes.
okay, all right. Dr.
I,
Court, you
I
have
see
another
that
question?
I see that you
I
feel
love
that steroids and say Motrin and Tylenol tends to work, right? Because I've tried that, especially when we go on missions.
Right.
A
Not
combination.
Tylenol. Tylenol is not anti-inflammatory at all.
But
Yeah, it's
At
not.
all. And
It's
it's the
not
but
anti.
leading cause of liver failure
Right.
in the country.
it.
So if you have itis, Tylenol isn't going to help.
I agree. I
no,
think it's a
no,
great
but it's a
point.
combination. When you combine that with the ibuprofen,
Well,
anti-inflammatory, the pain tends to get better.
it does, but I would say in my practice has changed somewhat. I don't offer Tylenol Motrin first line anymore. I actually steer patients towards turmeric-based medications or supplements. It can, but Dr. Court, you might refer somebody that's on 2 blood pressure pills and a blood thinner, and it's like, giving them a Motrin ibuprofen can make that worse. I'll get pushback from the primary care. So it's somewhat experimental, but I think if you have turmeric curcumin, which is there's numerous studies to support that it decreases inflammation. I think that's a great alternative to your Motrin ibuprofen medications and the Tylenol. Dr. Sprott brought up an excellent point. Too much Tylenol is not healthy. It's something that has like been around forever. And I don't necessarily look at it as a go-to as much as I used to. And I steer patients more to natural supplements, and many of them now want that. They come in and say, you know what, I don't want to be on special medication. I want something healthy and natural.
Hmm.
And I think that's something, maybe Dr. Bay, your
Yeah.
nutrition background, you might have something to say about that.
Yeah. I know that we do refer patients to those natural. What are the ones that you use that, because me referring them, but you're every day,
Right.
you prescribe it and then you see the result. What are
Yeah.
the ones that you feel truly give you the best result?
So the point I'll make about that is, I'll just say black seed oil and curcumin or turmeric. I think those are two good anti-inflammatory natural things we can use. However, the issue is bioabsorbability. We can take
Hmm.
it all we want to. We can, ginger as well. So oftentimes people will chop it up or they'll make like a shake or a mixture. The body tends to get rid of that, right? And so um, I do use a particular company called Three International, and um, their product is third-party tested for bioabsorbability, and it's one of the best on the market. So it's one thing to actually say what turmeric does. It's the other
Hmm.
to say, will it actually have an effect? Will your body get rid of it? And so the encapsulation of the product that I like for my patients is encapsulated in such a way that it does not degrade with the acids in the mouth and the stomach. It actually gets to the bowel and absorbs, and so it has a 3 times better absorption rate than what's on the market. Third party tested. I do represent the company, so I have to disclose that. But based on my practice, I am seeing results where people feel decreased pain, decreased aches with this, and I think there's value there for it.
Hmm. What's the name of the company again for we
It's
can
called Three International. Let's see, I have one sample if I could show it. It's not really showing up
be
well.
international?
Yeah, Three International. It's called Revive. Three, yeah, I don't know why. Yeah, Three International, and it's called Revive. Is the product that has resveratrol, which is an antioxidant, ginger, black pepper. Let's see what else. Grapeseed extract, shiitake mushroom, and so I would push. I tend to recommend that to patients, and it seems to do well. The issue always with folks is the budget. It's
Yeah.
cost. You have to order it online. It's a supplement. It's not
Right.
FDA approved. It's third party approved. It doesn't.
Yeah.
Supplements don't go through the FDA.
Hmm.
So I encourage people to do their research on it,
Yeah.
and see if it's for
Always.
them. But I have used it in my practice and find value there.
Okay, excellent, excellent. I'm glad you said that because I'm into the nutrient aspect as
Yeah.
well.
Yes. Yes.
Anytime I could get this professional, you know what I mean, it's valuable because you see it every day.
I see it every day, and I would also say that. I recommend a daily supplement of vitamins. We see vitamin D deficiency,
Hmm.
coupled with calcium deficiency, is particularly in women who come in with osteopenia, like thin, weak bones. I
Hmm.
would argue that knee pain in some patients is osteopenic pain, not arthritic pain, where their
Hmm.
bones are just weaker. They're thin. It's a weight-bearing bone, and you get X-rays, and you don't see bone on bone, and you get an MRI, and it's very, it's called like equivocal. It's like could be something, could be not. There's not that robust pathology.
Hmm.
Do notice this patient is osteopenic or osteoporotic, and you
Right.
and they're just their bones are weak and they're walking around and it's like, why does my knee hurt? Why does my knee hurt? And oftentimes, or in my practice, I will actually inject a calcium phosphate into the bone itself,
Hmm.
so that they have more structure. I
Hmm.
do enough total knees that I see variability in the tibia, particularly where, after we make the bony cuts, you look at the bone and there's patients with spongy tibia. You could literally push your finger into their bone and make it depress your finger. Whereas other people, it's sclerotic like marble. You can't. It's hard as a rock. And a lot of those patients present with arthritis, but I think there's more to it
Hmm.
than just arthritis. I think there's a component of malnutrition and chronic osteopenia that contributes to some of the joint pain that they have.
Excellent, excellent. Dr. Garrison, Dr. Sprock has his hand up, but this is what we're going to do. Dr. Garrison, can you introduce yourself? I know you have your hand up, but then I'm going to go to Dr. Sprock and let him get his question. Okay. You're on mute.
Good afternoon, everyone. My name is Jordan Garrison. I'm a surgeon in Hackensack, New Jersey. I specialize in venous disorders. I'm so glad to be here. I missed you guys. Good to see you, Dr. Sprott, Dr. Lee, and Dr. Court. It's good to see you guys.
Yes,
And
sir.
I'm here. Okay,
All
I
right.
do have a question for Dr. Lee,
Go
but I'll
ahead,
wait my turn.
Jordan. Go ahead.
You all right?
Go ahead,
Okay.
Yeah,
Jordan.
yeah,
Yeah. Um, in my practice, when I look at legs every day, I'm looking at
Yeah.
hundreds. The most common two things I see is obesity
Yeah.
and knee surgery.
Hmm.
I've never seen so many scars on knees in my life.
Right.
And I'm glad and I'm sorry I caught the last end of this, but it's given me some relief because I'm trying to figure out why so many, what's the relationship to all these people with vein disease and knee surgery. So I'm open to hear more. Okay. So
Sure, sure. Yeah, I would say, you're probably seeing like the venous stasis and, the circulatory issues in your practice. And I would say, it's general health and wellness, right? If it's maybe obesity, like you mentioned, the veins are no longer um, as efficient as they were. I've referred patients to you for the vein evaluation, and you find you
right.
do a vein exam, and those valves are inefficient. I think it has to do with lack of activity, obesity, chronic inflammation. I think all of us in our various subspecialties see chronic inflammation and the devastating impact it has. And so I'm sure you see it too. And I would say we're probably dealing with, a spectrum of disease that where inflammation is affecting not only the joints and the bone health, but obesity, diabetes, lack of circulation. And I think, our goal here hopefully is to get people to decrease that chronic inflammation, through healthy living, lifestyle, and not eating things that are going to, cause inflammation, processed food and unhealthy things like that. And so, yeah, I would agree. I oftentimes will see venous stasis and it'll present, they'll say, oh, my knee hurts. And I'll look and I say, you know what? I don't think so. I see discoloration. I see swelling. I see bruising. They'll ask me, Dr. Lee, why do I have these dark spots on my leg? And, I said, your veins, the blood is pooling your legs. It's, I tell them the blood is pigmented dark. If it stays in one, location, it's going to look dark. You have these spots on your leg. And I would steer them away from knee replacement because I don't think it's going to help them in that regard. And, maybe they do have an arthritic knee, but I do think there's value in getting a vein evaluation because oftentimes when I do a knee replacement, the swelling is worse post-surgery. People, I explain it. So listen, after your knee replacement, there's going to be a few days where, the surgical site will be inflamed and the blood from that area is going to track down your leg and it's actually going to be worse. So you have to understand those first couple of weeks, your ankle is going to be swollen. You got to keep it elevated and they have to know, I will get it phone calls all the time. My leg's swollen. Is that normal? It's not normal. I say, yeah, it is. It is normal. It usually corrects over time.
Okay. Thank you.
Dr. Sprott, please.
I'm going to just add something for people to consider in terms of um, natural medicine products. There's something called cat's claw,
Oh,
and cat's claw has nothing to do with cats. It's a plant in rainforests in South America. It's long been used. It's purported to be a potent anti-inflammatory um, sort of natural supplement. Um, and it's also thought to have some anti-cancer properties, which again, some people think that inflammation has a lot to do with why cells might become cancerous. And so it's something that I've been taking for maybe about 8 years. And one of the things and it's supposed to also be very good for digestive problems. But, as we get older, a lot of people, friends, relatives have had issues related to memory. And a lot of commercials that are online about or on TV about, things like Prevagen and other things. And so people have asked me about, well, does that help and work? And the website that I normally go to help me answer those questions, I've mentioned it before on the webinar, is the National Institute of Health website called PubMed,
Mm.
PUBMED. And so I went to PubMed and I asked Prevagen and memory loss. And this article came up that looked at all the medications and supplements that had been researched. And lo and behold, one of the properties that they thought dealt with two of the aspects of Alzheimer's. The plaque formation is one, and the detangling of nerve endings was another. Cat's claw was demonstrated in animal studies to affect both of those components to possibly increase memory. And so I would say that if you are interested in, and again, one of the issues related to Alzheimer's is also the inflammation that's been associated with it. I had a personal issue with my mother-in-law who lived with me for 15 years with Alzheimer's, and ended up giving her some Vioxx, which is a non-steroidal anti-inflammatory medication that was used and made a lot of money for Merck. She had no intelligible speech at the time that she fell at our home and broke her hip, and she got pinned. And when she came back from the hospital, she couldn't walk. She grabbed at her knee. She couldn't say that she had knee pain, but she looked like she had knee pain. We put her on another anti-inflammatory. Celebrex didn't help. Put her on Vioxx. Immediately, she started to walk. And after a week, she started to say words and then put words together. And the only thing that had happened in terms of her decline, where she couldn't say anything at all, was this Vioxx, which now she started to work. And so later on, they started to demonstrate that there was an inflammatory component to Alzheimer's that might have been what the Vioxx did to help improve her ability to speak. But I would say that if you are interested in a natural plant that has anti-inflammatory properties as well as other properties in terms of possibly helping with maybe the prevention or maybe the improvement in Alzheimer's or dementia associated with it, consider looking up cat's claw. Talk to your doctor about it. I've mentioned it to my internist that they should look at it, see what they think about it. I've actually shared with them some of the articles, and now there are even more articles on PubMed about it and its properties before.
Mhm.
But the question I wanted to ask you, Dr. Lee, was a lot of, especially women, that as they get older start to lose height. They've been 5'8",
Right.
5'7", 5'6". Could you explain what the process is where people start to lose inches and whether or not there's anything that could be done to try and prevent it or slow it down? We know that there are lots of issues related to loss of bone or loss of calcification and DEXA scans and, again, sometimes expensive treatments that we're not sure about. Could you talk about that a bit?
Yeah, sure. It's not just women too, man. I think men as well. I think part of it you mentioned is bone loss. So when I was a resident, we used to say the term that osteoporosis is a disease of childhood. It's when because you don't get enough calcium and vitamin D when you're young, and women especially postmenopausal, they lose it, And what can happen is the bone density in your spine can diminish, and the height of the vertebrae, which is like a square or box, can shrink. And so, the extreme cases, we've all seen the lady walking down the street like this over time. That's osteoporosis from the cervical spine because their center of gravity changes. When the block of bone no longer can support the weight of their spine, their center of gravity changes and they bend over and walk like that. That's coupled with loss of muscle mass. We lose a pound of muscle, 30 and over, we lose it. If we don't make it up or work out, stimulate our body, then these things happen. So I would say it's, I'm oversimplifying it, but I would say there's a loss of bone mass. So in the spine, particularly, change in the center of gravity, and then also a loss of muscle mass, where your posture changes, your ability to keep your head up, balance your body weight also changes. So if you think about it, if your bone's thin, your center of gravity slowly changes. You're not stimulating the muscles the same way. You're not able to. You lose muscle mass, you lose bone mass, and then it just gets worse and worse over time. And so I think it's preventative maybe earlier on in life, maybe around interventions around, the perimenopausal time should also be considered when maybe somebody's in their late 30s, early 40s. So that 20, 30 years after that, they don't have that calcium deficit. If you think about it as like a bank, you got to store your money away. And then if you got to withdraw, and then you're like negative, and you start to lose the body, the bones will release calcium into the bloodstream. If that happens, it takes it from somewhere. It has to take it from somewhere. It takes it from your bone, your skeleton, and it takes it from the spine. You lose inches over time, and then the muscle changes, and I think it just becomes something that gets worse.
What
Just
about
one quick thing, and this deals with you, Omar, and as well as Dr. Lee. It just, these things pop up. You mentioned osteoporosis, which is sort of lack of the bony calcification, being a pediatric disease. And I recall a certain group of babies that end up having osteoporosis because of lack of vitamin D.
Right.
And the issue is that most of the newborn formulas put in A and D because breast milk doesn't have much vitamin D.
Mhm.
And so what would happen is we'd have mothers, and we're big proponents of breastfeeding, but we'd have mothers that were exclusively breastfeeding the babies. And there were a segment of the African population that were Islamic, that had heavily garbed. And the babies were dark skinned, which meant that they produced lots of melanin, which decreases the ability of the sunlight to activate vitamin D. And these babies in particular started to have osteoporosis. And so it was one of our nutritionists who said, hey, this is something that we've seen. It's preventable if we provide the babies with vitamin. We don't want the mothers to stop breastfeeding, but they need to understand that there's no or very little vitamin D in breast milk, and they aren't being exposed to sun because they are being heavily garbed, and their skin is very dark, which means that it's blocked, the melanin is blocking the ability of that to happen. So people need to understand that if indeed you're breastfeeding, even though there are all sorts of benefits from it, you need to think about the ability of taking the vitamin D supplement in order to prevent osteoporosis from occurring, because it really was a serious problem.
Yeah.
Mhm. Now you're talking about the moms taking vitamin D, and the baby will
The
get
babies,
give it to the baby itself.
yeah, the babies, because the mothers usually don't have osteoporosis.
No, I
Okay?
understand, but I think with the breast milk, I was thinking the vitamin D would come through
No, there's very
but you
little
give it to
vitamin
the
D in
baby
breast
itself.
milk, even though
Gotcha.
the mother doesn't have any deficiency, and the mother usually is drinking or taking products or supplements that
Mhm.
have vitamin D. So they
Okay.
didn't have it, just the
Mhm.
babies.
Yeah, I got you. Got you. We have several questions that have come up. Jordan, is your question short? Short, right.
Never.
So let's do this. Let's do this.
It is very, very short.
So go ahead, because I want to get through these two questions, and then we're going to take our break. And then, James, maybe we can see some of the videos that you
Oh,
or
sure.
pictures that you in the
Absolutely.
second half, and then we can get some more questions done. Go ahead, Jordan.
This is more of a comment and then a question. Dr. Sprott has always been an advocate of other ways to deal with health. And I remember maybe 10 years ago, he was advocating for anti-inflammatories for Alzheimer's disease and other kind of brain products. And so now with the cat's claw as well. But I just wanted to add on, the vein literature is replete with references to an anti-inflammatory agent, and that is horse chestnut. So that's just an addition to what Dr. Sprott and what Dr. Lee are talking about. That horse chestnut also decreases the amount of inflammation in our bodies.
All righty. That's a new one on me. I'll have to do some research on that one.
Yeah.
Horse
Okay.
chestnut. Okay. Welcome, Patrick.
Hi guys, sorry I ran a
Can
little
you
late.
introduce yourself, Patrick?
Yes, can you hear me?
Yes, we can.
Yes, Pat Anderson, G1 oncologist, working out of the Barnabas system. Good to be here.
All righty.
Apologize for being so late.
No, anytime, brother. Anytime. We're just happy to have you. Um, there are some questions. I think somebody may have answered one of them because or answering one of them, but also as far as turmeric, and we had talked about turmeric, um, it states also, do we get benefit from turmeric when we use it in cooking, such as stews? So obviously, this person adds it to her food or in cooking. The question is, once it cooks and heat, and does it change the character to the point that you're not getting the benefit? Can you give us some enlightenment on that one?
Yeah, I would say you don't get as much benefit. I would venture to say you cook it down and then it has to go through your, the acids in your mouth, your stomach, and eventually get to the bowel to be absorbed. If it's in food, I would say it's maybe more limited. That's, when I did a literature search on turmeric or curcumin, it talked about the wonderful anti-inflammatory aspects and how it inhibits interleukin 6 and tumor necrosis factor, but it also made it a point that it doesn't bioabsorb very well, meaning getting into your bloodstream. And so I think, I couldn't give you an exact answer in terms of the quantity, but I would say if you cook it and it goes, you ingest it through food, I think there might be less benefit than taking it in a encapsulated form where it can make it through the digestive tract and, eventually absorb.
Okay.
Yeah, I
And
responded to that with and I
yeah,
said
well,
basically the same thing.
can you, Kendall, can you just talk about the cat's claw and what you responded, because it's interesting. I think the public would like to know what you said about the.
Yeah, I've been taking it in capsule form, and I don't want to plug Amazon, but I get it from Amazon. But I would say to um, James' a point, a lot of the companies that make the supplements come from all over, and how well they get the product, make the product, make sure that it's purified, and this is can be suspect. But I've taken it in capsule form. I think I'm taking like 1,000 milligrams capsules, and that's what I've done.
All
Yeah, I would
right.
agree with that. Yeah, some of these fillers that get into the supplements, you got to watch that. And I think it's important to do research on, ones that are actually truly giving you benefit.
And once again, and Omar stressed it, when you read about it, bring the information to the doctor, your doctor, and let them say it. Because, one of the concerns I've had, and people, and Jordan, you can weigh in on this. A lot of the folks that are on medication because they have atrial fibrillation, and I thought saw Trevor a while, but they're on blood thinners.
Yes.
And a lot of the blood thinners, they say taking certain anti-inflammatories are contraindicated, and they don't want to take not only medications but also supplements that might be. They're concerned, and the doctors may or may not know enough about it, because one of the problems with what we face today is that a lot of the biomedical research is done by pharmaceutical companies.
Yeah.
They're the ones that do the studies. They're the ones who go through this elaborate process of having the FDA approval and everything else. Most of these things that are natural, the pharmaceutical companies, I shouldn't say are not interested at all, but they usually can't make money because they can't get patents on something like a plant. And
Right.
so you don't necessarily get the kind of research or FDA scrutiny that goes into a lot of this, as well as some of the complications of having them with on along with the different other medications. And some of our brethren are on 5 or 6 different types of medications, and the drug to drug interactions that may occur with these supplements and not, the people that ask you the questions have a list of everything you are, but I don't know that there's a database that can let them know that these things are contraindicated or not. I just don't know. But you have to be careful by in taking something that may interfere with the medications that have your blood pressure controlled or your diabetes controlled, and
Mhm.
with some of these other products. We just don't know because I don't think they've been studied.
Yeah. The thing of it is that there are those physicians out there that are natural medicine that truly have gone to medical school, but practice natural medicine. And if you're in the area here, South Orange, Maplewood, New Jersey area, there's one doctor that I refer a lot of patients to. His name is Dr. Kevin Holder. He happened to have gone to medical school with me, and then when he came out, he decided to practice natural medicine, and he's been doing that for 40 years. So somebody like that, is
He
somebody
trained
that,
under me too, Omar.
yes, he did. Somebody like that is worth listening to and worth, seeking that knowledge about natural medicine. Let me do this. Let's do our halftime break, and then Patrick, you're going to be up next after that with your question, and then we're going to go to James's videos. Patrick, can you start us off? Introduce yourself, please.
Yes, hi everyone. Happy to be here. It's Patrick Anderson. I'm a gynecologic oncologist, and I work in the Newark, New Jersey area out of the Barnabas system.
Thank you. Dr. Lee. Dr. Lee, please.
Yeah, Dr. James Lee Jr., board certified orthopedic surgeon, private practice in Paramus and Parsippany.
All righty. Dr. Sprott?
Kendall Spratt, graduate of Morehouse College, New Jersey Medical School, now part of Rutgers, board certified in pediatrics, did 15 years of critical care pediatrics, and then the rest general pediatrics.
And Dr. Court, please.
This is another James on your panel. This is Dr. James Court, internal medicine, East Orange, New Jersey.
All righty. Dr. Garrison.
Jordan Garrison, surgeon. I specialize in venous disease and disorders in Hackensack, New Jersey. Good to see all the docs online. Patrick, could you give me a call after this? I have an interesting patient I need to discuss with you
Yes, sir.
regarding pelvic congestion syndrome.
Yes.
Excellent, excellent. And I'm Dr. Omar Bey, pulmonary critical care, retired, and now doing more. My subspecialty is nutrition, and I'm director of nutritional support at Bethesda Medical Center for the intensive care unit. What
When
I'd
did you
like to do,
retire?
excuse me?
When did you retire? Last week?
Last year, July
No, he.
last year.
I think he's
Closed the
punking us.
office.
No.
In a year, it flew by.
He still
Partially
works every day. He
Partially.
still comes there every day.
All righty. So the, every second Saturday, this webinar comes on, and please, it takes a village. Tell family, church members, friends about us. Just tell them that OBHealthy is here to answer their medical questions, and also that for the audience out there today, don't be hesitant to type in your medical question. Type it in before the. Don't wait for the last 5 minutes of the show to type it in. Type it in now so we can answer your questions. The most important thing that I can say is please do not change any aspect of your medical care until your physician evaluates and understands what's going on. Check with your physician because only they can truly take care of you from a medical standpoint. All righty. Also, I would like to thank OBHealthy for allowing us to bring this webinar to you because without them, we just couldn't do it. Patrick, go ahead.
Um, this may have been addressed. I apologize for coming in the middle, but more for Dr. Lee. With respect to turmeric, it seemed that the absorption and the inflammatory properties are enhanced in combination with other supplements that has capsaicin in it. So oftentimes I see some of the recommended preparation, especially the cold press with citrus. They ask that you add black pepper to it.
Yes.
A little bit pungent, but can you expand on that kind of a combination?
I agree. So we did briefly talk about it, but one of the supplements that I recommend, and I tell people to do their own research, is from a company called 3 International. I'll just read the ingredients. So you basically read, like you just mentioned, turmeric is in it, boswellia, boswellic acid, black cumin oil, grape seed extract, sea buckthorn, shiitake mushroom, black pepper extract, ginger root oil. So the combination of multiple anti-inflammatory natural products, I would agree with you. I think it's cumulative. It seems to work. And I mentioned earlier the reason why I like this particular product is the bioabsorption. Patients
Yep.
mention I make a shake or I chop up ginger, I chop up I have turmeric, but how much of it is absorbed? I don't know if we have the true answer, like Dr. Sprott mentioned, but looking at third-party tested supplements, I think is the way to at least go to get more information.
Excellent, excellent. James, what we like to do is you want to bring up your slides and we can go through some of the interesting stuff that you showed me earlier because I think it was
Yeah, absolutely. I was originally going to do the more like the healthy joints, but I think we've talked about that for the most part, in terms of what to do, exercise, keeping the inflammation down. I'm going to pivot a little bit to a little more tech and just go over some brief slides, talk about some of the robotic technology used. I'm going to share my screen, and then I'm going to pull this up here. You seeing it? Let's see.
Not yet. You should be able to share though. There we go. Yep.
Okay, great, 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 great. Okay. So so I gave this talk to some graduate students in Malaysia. Actually, I had like remoted in, and they wanted to know a little bit more about robotic knee replacement. Some of these questions are not necessarily relevant to what we're discussing in terms of cost and so forth, but I think there's some interesting clinical photographs that we can go over. So this is one of my patients, early 50s, obese female, presented with severe knee pain. And I think, for the younger people looking and the docs here, if you look at her gait, you clearly see she's got a very bad knock knee, or valgus knee, we call it. So the orthopedic term is valgus. That's when the leg points to the side. Varus is when you're bow-legged. I'll play the video again. This is somebody that had previous surgery on that knee and injections weren't working. She's relatively young. And so it's like, what do you do with that? And I think that's a challenging case, because not only are you dealing with the bone itself, but all the ligaments are not balanced anymore. So you can imagine on the inside part of that knee over here, those ligaments are stretched, and then these ligaments are tight. And so when you approach somebody like this and say, and they come in and say, well, Dr. Lee, can you replace my knee, fix it, make me straight? We say yes, but we sweat a little bit in the back room, because we know that correcting somebody who's walked like this for many years isn't always straightforward, because they're used to that position, and the tissues around their knee are used to it. The nerves, the muscles, they've assumed that stretched, contracted position on one side of the knee, and on the other side, they've assumed a loosened position. And so if you correct them, you have to counsel the patient that, hey, I'm going to try to straighten your leg out. I'm not going to overcorrect it. And I have to counsel you that, the shift in your knee joint may, stretch the nerves on one side and cause you to have weakness. And so, this particular patient was my first patient that I tried a robotic knee replacement on. This is about 5 years ago. And so I've been mulling the idea. I did not train on a robotic knee when I was a resident. My father did not as well. We were manual. We have instruments that are manual. We get x-rays, MRIs, and we try to calculate the level of correction and degree. But we somewhat have to work that in during the surgery and balance the knee as best we can. When there's a robot involved, what we do is we get a CAT scan of that patient's knee, hip, and ankle, and then we calculate before they even get in the operating room, what does it look like when we correct that knee? How many degrees of correction? Do we cut the bone on one side? How many millimeters? And then once we do that, what size implants are going to work for that knee? And so when we use a robot, we're able to have, I would say the answer in quotation marks before the surgery starts. We've already calculated the roadmap, and then the surgery is an execution of the plan. And so this patient had the surgery, and this is what she's like post. This is about maybe 4 months. And so big difference. She's still a little bit valgus, still a little bit knock-kneed, but not the severe deformity. And no cane. She's back to work. And I would say that's successful. And so it's like, when I did that surgery and I used the robot, I was skeptical. I was like, I don't know if this is gonna work. I was very concerned. But it did sell me on using some technology to help with some of these difficult cases and deformities. And, that's a younger person. She's probably late 40s, early 50s. That, she's going to live another, God willing, 30, 40 years. And you want to make sure that, the knee is right. And, there's some risk involved in an extreme case like that. And I will say, it sold me a little bit more on the value of the robot. Let's see here. We did that. And so this is her x-ray. All right. So if you look straight on the right, when we do our x-rays, this is actually the right knee. This is the left knee. Even the left knee has arthritis, but look how crooked that is. I mean, that is a severe bone-on-bone deformity. That's what we mentioned earlier in our discussion. We do our screening x-ray. And when you're bone-on-bone, I'm not recommending gel shots. I'm not recommending, steroids are not really going to help you. Stem cells aren't going to help you. I would not invest money in those products at this stage. This is like probably one of the worst you'll get in terms of what it looks like. And if you look at the X-ray, post X-ray, it looks pretty good in terms of the radiographic outcome. And so that's the pre and post.
Mm-hmm.
And then this is what it looks like in the surgery. So there's my former PA Winslow in the operating room with me, and these are what we call arrays. So when we do this surgery, what we're doing is we create bone landmarks in the knee. So this is the femur, this is the tibia, and that corresponds to the CAT scan that was done ahead of time. So when we register these bone landmarks, the robot needs to know that the CAT scan measurements it made are realized in real time. And that's why we put these pins in the bone in certain positions, and we have these registration points, and then the robot will verify, yes, okay, you pointed to this particular area in the knee joint, and we're registering landmarks, so it's an accurate representation of the knee. And so that's what that looks like. And then that's the cut. So for the young doctors, it's almost like a video game. We're going in there, and we can't go out of bounds, if you will. If you want to use a sports analogy, even if I tried to deviate from the surgical plan and I tried to pull on the robot or do anything, I can't. It only allows the bone to be cut in a precise fashion. So for the folks who are really into video games and this is kind of like what that is. You're using three-dimensional manipulation. You're looking at a screen. You're using a templated plan. As a surgeon, my job is to safely open the knee so that when the robot and myself perform the surgery, it's done in a safe fashion so that we aren't cutting any structures that are, critical, like a blood vessel or nerve in that regard. Any questions? Anyone use, Patrick, use robot, don't you?
Yeah, I use robot a lot. Really, really great advanced technology when you operate in confined spaces like the joint.
Right.
And the key here is, one, you mentioned the precision. Everything you cut is pre-measured, and you kind of can't deviate once the field is set up.
Right.
Most of what I do is soft tissue dissection in the retroperitoneal space, and the optics, the improved optics, just makes me wonder how some of the old surgical atlases, like the Netter Atlas, how precise they were
Yeah.
without the use of this video technology. But it allows us to see nerves and ligaments and blood vessels. So a lot of when we talk about nerve sparing and bloodless surgery, this also enhances that aspect of it. I've always been fascinated by the orthopedic guys who do such precise measurement and alignment, because oftentimes, as Dr. Lee mentioned, you become so used to a chronic state, and your body is now aligned in that chronic state. So now you make that one correction. He's not just correcting that one reference point, which is the knee joint. He now has to now correct the ankle, and probably at some point we'll have to make some adjustments in the hip and the pelvis in order for that person to be totally be comfortable. So this is just fantastic stuff.
Yeah, one thing I have to say is if I were to be academic about the outcomes of robotic versus manual, which is non-robotic, the short-term literature would state the outcomes are the same. Now, I don't know how that's going to work long term. And it's interesting, the fellows, the graduates coming out now that are coming out of the total joint fellowships, they're much more used to the robot as opposed to manual instrumentation. And they seek hospitals and locations that will allow them to use the robot. And not everyone has it. And, the technology may fail. Like, sometimes, one of these targeters may go off out of alignment. And I think it's important to have the background and knowing, how to bail and making sure that you can convert this to a manual procedure if need be. It rarely happens, but I do think there's value there too. In your world, Patrick, is there literature to support robotic surgery in your field is superior in outcomes? Or not? Is there a difference? Orthopedically, I cannot tell this panel of patients the outcome will be better. I can say it's more precise, but I can't tell
Right.
you the outcome is
So,
better.
so it's an interesting conundrum, right? Because, initially, and I've been doing robotics for 20 years already,
Yeah.
right? And primarily for cancer work. So when you separate long-term outcomes between what's done for cancer and what's done for non-malignant disease, you have to separate the two groups. But with respect to cancer work, there's some data coming out looking at long-term survival and disease recurrences in surgeries done open versus that done with the robot, the quote-unquote minimal invasive approach.
Right.
Um, and there's a large body of literature, especially in cervical cancer, that suggests that the open approach may actually have some long-term benefits over the robotic approach, even though the short-term benefits in terms of hospital stay, quicker recovery, diminished pain, decreased blood loss at the time of surgery leans more towards the robot. But when you take a critical look, then something that allows you to do such precise dissection, why then would the outcome be a little bit worse long term? And I think in operations where margins are important, right, and you rely on your natural visual acuity to determine those margins, sometimes when you have um, amplified or augmented optics, that margin which you think is sufficient may very well not be. Um, However, most of these surgeries that we do, the margins, the defined margins as to what's considered radical versus simple versus adequate, usually is based on anatomic marks, right? Natural reference points. So that dilemma still exists as to why there's a difference. My personal opinion is it all comes down to case selection. I
Yeah.
do believe that there's a category of patients that, when appropriately selected, the long term outcome is at least equivalent to the traditional approach. What we tend to do as surgeons is we often tend to push the envelope, and
Yes.
sometimes we move outside of what would normally be accepted for this approach. So, that I think we have to sometimes look at ourselves. And then there's the issue of operator experience, right? And like you say, James, know when to make the transition. This is not
Right.
about me. It's not about you. It's not about our egos, but it's what's best for the patient.
Hmm. Excellent, excellent. Dr. Garrison, your hands up, please. Oh, you're on mute, Jordan.
You know, it's funny about the natural progression of robotic surgery. You know, um, I did bariatric surgery for 20 years. In my last 5 years, I had championed robotic bariatric surgery. I don't know if you guys remember that initially when laparoscopic surgery came out and we were trying to do laparoscopic gallbladders, the older surgeons poo-pooed it. It's like, oh, no, no, you're going to make mistakes. You're going to cut the bile duct, et cetera, et cetera, et cetera. And what we found out that there were lots of advantage to laparoscopic surgery. Return to work was quicker, get out of the hospital quicker. I remember doing gallbladder operations. People are in the hospital when we did open for 5 days, 6 days. And then we did laparoscopic, and it was one day, and we even got to the point where they go home the same day now. Then the robot came out, and as a bariatric surgeon, all of the other surgeons were like, "Oh man, you can't do robotics on these obese patients." And initially, people found that if you did do robotics, you should only do it on the smaller patients. What I found was the robot was excellent for the larger the patient, the better the robot worked because of the angles that you had to put the instrumentation in and everything. And even to the point where it's a selfish thing, but it will add 10 years to the surgeon's career because I'm not leaning over 400 and 500-pound patients and my back is getting tired and worn out, et cetera, et cetera. So by your operator being more comfortable in doing the procedure, there's going to be less incidence of a complication caused by the operator. Also, the advantage of the robot is it gives you a stable platform. You don't have things moving around, getting in your way or shifting.
Mhm.
Once you put it in place, it stays in place. And for you, the angles of your cuts and things like that, it makes it so much smoother. And once you master the technique, you go, wow, why wasn't I doing this 10 years ago using the robot? You go home refreshed, you can do more cases, you have better outcomes from this. So I was a great proponent of the robot once I realized its usefulness in performing surgery, not only for the patient, but for the surgeon as well. So those are my comments.
You know, it's interesting, right? Because you know, we're often confined by the ability of the technology itself. You know, I did my first robotic case at Norbeth in 2001. And I'm one of those people who has worked with or have experience with every single model of the robot that we use for intraperitoneal disease. And Jordan, you know, we can talk about the history of the system that we use and how it was for the military and all this other
Mhm.
stuff. And it would make an interesting episode of the Doctor's Lounge, Omar, because you have Jordan, you have James, you have Kevin. We all use the robot. And you know, the sequence of how procedures are approved, you know, it starts in the pelvis with the urologist, with the gynecologist, now with the general surgeon, and even with general surgery was still essentially initially pelvic disease, doing inguinal hernias, and then the move to mid-abdomen. Now we're doing APRs and then upper abdominal disease, you know, hiatal hernia repairs and those kind of things. But what has happened over 20 years with each model change is the versatility of the robot, right? So if you remember, Jordan, the first two-arm robot, you could only have the camera in a certain arm and only you're restricted by two additional instruments. Then you went to that stable arm for the camera, then three instruments. Now you can put any instrument in any arm. So as the technology developed, so was the versatility. And then it allows you to work in multiple quadrants without even have to adjust or change your surgical field, right? So in the past, I would operate in the pelvis, then I would swing the robot over the patient's head and change the position of the table to do, say, an omentectomy, work in the upper abdomen. Now it's crazy. Now we have Bluetooth technology that link the patient's bed, the operating table, with the robot. And James, the model that you use, I don't know if that exists, but
Not
you know,
quite.
in orthopedic surgery, once he aligns his patient, he can't move them,
You
right?
can't
Now
deviate.
with the robot and the Bluetooth technology, once he aligns the patient, the robot and the bed can move in unison. Technically, you change his angle, but not the patient and the instrument orientation. So this stuff is
Mm.
becoming more and more fantastic. And I think, you know, for newer surgeons, you know, Jordan, I don't know, soon you may not be able to find a surgeon who can do an open knee replacement or even do an open laparotomy.
Right.
Yeah.
That's true.
Hey, James, I don't know what this picture is about, but I don't even scrub into my robotic cases anymore.
Oh, really?
I go
Right.
sit at a
We're not,
console,
we're not there
okay?
yet.
And I'm playing games with my
Right,
two
right.
fingers, man.
Right.
I'm jealous. I am jealous,
I
but
hear you. Kendall, go ahead and with your question, and then we have some questions from the audience. Go ahead, Kendall.
Yeah, Patrick kind of talked a little bit about what I was going to ask about, and that is one of the concerns I have. I mean, Patrick and Jordan and James are older folks and learned both issues in terms of how to perform surgery. So they know how to perform surgery in case something would happen to that because they learned the other way. But with the newer folks, they're only learning on the robot. Very few of the surgical procedures are being done in the old-fashioned way, if you will. And I'm just not so sure. And Patrick, you mentioned it, an inguinal hernia. Now, I'm not sure that an inguinal hernia is such a complex thing that would require a robot to help you repair. Now, again, I'm ignorant. I'm a non-surgeon. But, you know, I have a cousin who had robotic surgery for inguinal hernia, and he ended up having a removal of his testicle.
Oh,
And that's not to say that it was the robot's fault or the person's fault, but it got caught up in mesh or whatever. But I do know that a lot of folks, especially the newer folks, they're only trained on robotic surgery, and they don't know the standard of surgery that was done before. So I question the issue, and I'm sure for the more complex things than that, I just am not so sure in terms of the way that you do these comparisons, because if you look at what's happening now, if 90% of the knee replacements are done robotically, then how are you going to know about the long-term effects versus the older way? It's just not the same. You're not talking about apples and oranges. But I know that it's the way of the future. And as you said, Jordan, I mean, some of the things that are happening now in medicine with, I don't know if people saw the 60-minute episode on the neural bridges that are allowing people that had quadriplegia to be able to walk by having a link between the brain and receiver below the spine where the injury was, and they can now walk when they weren't able to walk because they bridged the gap between the end of the nerve that was severed and then the nerve below it that now is able to make them walk. And not only that, they're walking because they're thinking about the walking. They don't have to say a thing. And the other aspect of that is they now can cause a robot that's not even attached to them to walk by thinking. And so I think the issue of where technology is going is at a certain point scary when you think about some of these things that are being done to advance medical science. You think about these nerve implants that are allowed to take how you think about moving your arms or legs, and somebody hacking into that and saying, well, let me take control of that and cause this to happen. Because just as much as we're doing things for medical science, there are people that are looking to hack in to do these things for malevolent reasons. So I applaud the advancement of medical technology in order to make improved outcomes. I think in the future, the outcomes are only going to be who's doing which robotic surgery versus another type of robotic surgery that will be the outcomes, because they won't be going back to the older days. So that's just my 2 cents. But I did want to raise one question for you, James, because again, in pediatrics, and this is a personal for me, one of the things that we've had asked is about pigeon-toed or in-toeing.
Yeah.
When kids start to walk, a lot of kids walk and their toes are pointed in. And for me, it's interesting because I was pigeon-toed, I in-toed, and my son was born. When he started to walk, he in-toed. And my wife, who's OBGYN, was saying, we need to do something. We need to do something. I said, no. And so the issue for a pediatrician is when you look at why they're in-toeing, most of the times it's because they're in-toeing at the ankle as opposed to the shin. And so what we would normally do is to see whether or not the deformity, and it's really not a deformity, is what we call a flexible deformity. So if we can take that foot and turn it such that it's straight, that for the most part, it's going to correct itself over the time that it's 8 years old. So now I have a granddaughter, my son's daughter, who was walking just like this. And we need to get some special shoes, and we need to get I said, no, don't worry about it. Don't worry about it. And she's now just turned 5, and she's almost perfectly straight. So a lot of the people who saying, and a lot of people saying, you need to do something. You get in, that doctor doesn't know what they're talking about. Could you talk a little bit about that, James?
Yeah. So during residency, we saw you're mentioning, we call it tibial torsion. So, you mentioned the ankle, but there can be rotation of the tibia, and there also can be origin from the hip, where we call it version. So like where the femoral neck is in alignment with the knee, it could be forward or it can be backward. Retroversion if it's back, anteversion if it's forward, and that can contribute to this. We used to tell the parents and children, sit Indian style. Try to like externally rotate so that you don't internally go into. If you sit Indian style, you go out to the side as well. And we would, they would worry, but we'd follow them, and they would do fine most of the time. Rarely was there an intervention done. If it's you mentioned a good point. If it's a fixed deformity, if it's a contracted deformity or a bony deformity, that's different. If it's soft tissue, with time, stretching, sometimes it's prompting them to walk a certain way. Most of the time, it does get better without any advanced treatment.
Thank you.
Sure.
Excellent, excellent. We got a couple questions here, and let's, Jordan, I know you have your hand up, but can we do these? I think they're quick questions, and let's do these quick questions, and then we'll move on. Um, I'll do the first one. For some time, I've been experiencing numbness, tingling, as well as pain, coldness, feeling like things are crawling in my legs and fingers, but mainly my legs. Should I have my PCP refer me to a podiatrist, a vascular person, or an orthopedist? She doesn't say whether she has diabetes or, you know what I mean, that type of stuff, and it's just related to diabetic neuropathy. But just give me your opinion, James.
Sure. I see this commonly. If this patient presented to my office, I would do a neuro exam, check their pulses, check their circulation, check, under their feet, make sure there's no ulcers or breakdown of the skin. If there's any weakness in the muscle, if we do like a nerve test, if I suspect that it's a nerve that's pinched, you can get what they call an EMG, like a nerve conduction study, to see if the nerve is pinched or irritated in some part of the leg. That can also screen for neuropathy too, based on the EMG. If not, if it's, the circulation's in question, maybe, look at their toes. They don't blush the same way they're supposed to, or there might be some pathology there, a vascular referral. But I think this person, I would just consider a general workup, EMG, physical examination, and then see if we could, pinpoint whether it's a vascular issue, nerve issue, or maybe both.
One other thing we should think about in someone like this is their history. Do they have a history of a malignancy? Were they treated with certain types of chemotherapy?
Yes.
Because certain of these agents can cause a neuropathy and they can have the same kind of sensation.
Right.
I would agree with that.
Hold on just for a second. I didn't realize that the audience is not seeing the physicians. James, can you pull down this slide? Um,
Oh, sure.
yeah, so the audience can see. Yeah, just unshare for a
Okay.
while, so
Got it.
until
Okay. Got it. Okay.
but we
No
can
problem.
go back. Oh, thank you. I didn't realize. Sorry, audience. I didn't realize that we weren't seeing the physicians. Go ahead, James.
Yeah, no, I agree with Patrick. I actually saw a case like this the other day, and it was a young lady who had inflammatory bowel disease on, treatment for it, and she was on medication. And I had no, she kept saying she had numbness in her foot, and all her only positive finding is I tapped the top of her foot, and she would get this really intense pain. But in terms of her MRI was clean, physical exam otherwise was normal. And I asked her, I was like, what do you want? And she was on chemotherapy. And I don't know enough about that to know the neurotoxic effect, but I do think there's probably some origin there. Otherwise, healthy 33-year-old patient. And I think, Patrick brings up a good point, the history, what medication they're on, were they on chemotherapy?
Omar, to answer the question was, which doctor should I go to?
Yes.
I think they can go to anyone on this panel, because we are all trained to recognize certain things, and we will all refer that patient to the appropriate specialist.
Mhm.
So I think starting with anyone here would be a good choice.
Yeah, yeah. Well, the way I think of it is, and you're right, Jordan. But I always say, start with the PCP, and that's
Internal
what she
medicine.
said. Which would should I ask my PCP to be referred to? Um, but they're going to have their opinion as well, and they're going to do the actual exam. History and physical exam means everything when something like this is occurring. So, your PCP should it should guide you in the right direction. Yeah, excellent, excellent. The second one is Dr. Lee. Can you tell me the brand of turmeric combo that you stated earlier? I missed the name. Can you
Oh,
say it one more time?
yeah, it's called 3 International. 3 International, and the product is called Revive, Revive.
Mm-hmm. Mm-hmm. All righty.
Yeah.
The next one is, please, can you tell me what is the minimum units of vitamin D is recommended for a 65-year-old with deficiency? And do I need to take vitamins with it as well? I guess a multivitamin they're talking about. Okay, Dr. Court, when you give vitamin D, what for an adult? Where are we in the range of vitamin D, or is there a particular brand or anything that you use? And Jordan, you raised your hand just then. You can comment as well.
I'll wait for Dr. Court.
Okay.
It will depend on the vitamin D level.
Mm-hmm. Mm-hmm.
Say vitamin D normally should be between 30 to 100. And if it's below 30 and the actual number is 20 or below, I would give them a prescription for vitamin D2, 50,000 units
Mm-hmm.
once a week for 12 weeks. If it's above 20, then vitamin D3, 5,000 units over the counter daily.
Mm-hmm.
So again, you must know where your vitamin D level is. If it's, say, below 30 but above 20, that would require only the D3, 5,000. If it's below 20, with D2, 50,000 units once a week for 12 weeks.
Yeah. Now, I have a question. They're talking about vitamin D, but I hear about this thing called K2 and how it's related. Does anybody have any experience with that as far as what it does and how it is related to the vitamin D? Anybody? No?
Yeah.
All right,
I'm familiar with it.
we'll get back to that. I was just hearing about that. Um, um, Let me see now. There was one
Well,
more.
I just remember, we also have to understand vitamins and how they're absorbed and
Hmm.
stored, and the excretory threshold that the kidneys have. And this may be a question Dr. Sprague asked me in rounds one time, and I may not have known it, and I hope over the years I learned it. But there are vitamins that are fat soluble, right? Which when you take them, you're not going to get rid of the excess, you're going to store it, right? And there is outcomes, symptomatic features of when you have like too much of those vitamins, unlike a vitamin C, which you get your kidney tolerates so much, then the rest of it comes out in your urine. So when it comes to like vitamin K and vitamin D, it's important that we know the level and how much to take, because too much, you're just going to hang on to it.
Hmm.
A, D, E, and K.
Yeah,
A,
Very
D, E,
good.
and K
Very
are
good.
fat soluble, and B and
I,
C
I,
are
I knew
water
I
soluble.
knew he asked me that question in rounds one. All
just
A,
to add
D, E,
on
and
what
K.
Dr.
That's exactly correct.
Yeah, just what Dr. Court said was
That's
the
correct.
50,000. But just to add on, some people can't tolerate it all in one day, and we
Right.
recommend it per week. So some people take 10,000 5 times a week. Um, but as long as they get that 50,000 in, and the other thing is tell them to go outside and get a suntan.
Yeah,
For
yeah.
30 minutes. But you can't do it in the winter time. So,
Oh, yes, you can.
and it's direct sunlight. So not it's sitting in the car.
All righty.
But I do have a comment, and
Hmm.
before we move on, because we got a lot of things to talk about. We're talking about vitamins, we're talking about obesity. I have a comment and then a question for Dr. Lee. The comment and along with Dr. Sprott was saying is, yes, I know general surgeons now who don't know how to do an open gallbladder operation. They just don't have that experience. So what do you do at that point in time? So that valid point that Dr. Sprott was bringing up about the inguinal hernia repair, all of a sudden we've taken a simple operation and made it very, very complicated and very complex. And the cost of doing that operation has gone up and up and up and up. And the reimbursements are going down, 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 down. So we as have a responsibility to try to balance those cost benefit ratios. And that's a part of us being physicians. But my question was to Dr. Lee that this lady that you used in this example with her knee valgus and her obesity, how long will that operation last if we don't address her obesity problem?
Very good question. I can't give you an exact answer, but I will say that if her obesity worsens, then her outcome will be compromised. I think I can safely say that. Um, she did, this particular patient did lose weight, but I think some patients want the quick fix. It's like, they come in with poor diet, obesity, knee hurts, and they focus on the knee when, we as physicians, we see the bigger picture. Dr. Cord, he's the general practitioner. He knows these patients pretty well and, can refer for it. But if they're not, dealing with the bigger picture, weight loss, exercise, then, fixing the knee, quote unquote, and doing a knee replacement may not necessarily help them in the long term.
Okay.
Yeah. Dr. Sprott, please, your hand's up.
Yeah, so with the vitamin D, I talked about this issue in these particular kids, but I think there's a difference between deficiency and then trying to get to normal. So, for something like iron deficiency anemia, one doesn't start to drop the actual level of hemoglobin until you go through all of the stores of iron that you have in your body. And so in order to treat iron deficiency anemia, you need to replace the stores and then start to continue to treat for 3 months beyond that in terms of trying to get the patient back to normal. So you can get rid of the anemia, but the iron deficiency will still exist. And so not only do you have to treat the anemia, you have to treat the deficiency to replete the stores. And I think the same thing would hold with vitamin D. For kids, we talk about 400 units to try and prevent them from having issues with vitamin D deficiency. And I think the same thing that Patrick talked about is trying to get the stores back to normal. Since it is stored, you kind of want to make sure that you have a buffer zone to sort of be able to release the vitamin D if indeed your intake or your exposure to sun isn't sufficient to keep it up to normal. And Jordan, you were right, is that even in the wintertime, you can be exposed to sunlight, even if it's cloudy, that will activate vitamin D. Now, your ability to activate vitamin D will also depend upon the level of skin melanin or pigment that you have in your skin. But yes, you can activate vitamin D by exposure to sunlight, even if it's on a cloudy day.
I have a question for Dr. Sprott. I see some balloons in the background. Did you just celebrate your 90th birthday or something?
Not quite. So Sunday was, if you look at the two numbers, it's a 4 and an 8. So that's on Sunday. I've been married to my wife for 48 years.
God bless.
So
There you go, baby.
I'll show you this.
Oh, wow.
All right. Yeah, there you go.
That's 4 dozen roses for 48 years. We got married 2 days after we graduated from medical school.
Wow.
So that's what the balloons were for.
Okay, what's your secret? What's your secret for longevity of a marriage?
Choosing the right one.
Ah, there you go.
Yeah. So, a lot of times, you don't choose the right one, and a lot of your friends know that it ain't the right one, and it doesn't work out.
And they don't fess up. Huh?
Yeah. And the other thing, is true is happy wife, happy life. But I think, it's important when you're married that there's an element of compromise that you have to have. But, I've always tried to approach things through logic and analysis. And so I've always thought about, what am I hoping to accomplish when I either say something or do something, or don't say something or don't do anything? And so, when you start to do that, you can anticipate your wife's reaction to what you did, what you didn't do, what you said or you didn't say. And if you can anticipate what that reaction is going to be, and you don't want that reaction to occur, then you need to say or not say, or do or not do the right thing. So for me, I think that's an important part of it, because if you take responsibility for the way that your spouse treats you, then you'll not have a lot of problems. But if you don't take responsibility and you blame the spouse for what it is, then you can get yourself in a world of hurt.
You're very eloquent in saying something that means stay in your lane and shut up.
You know, I referenced the issue of living with my wife's mother who had Alzheimer's for 15 years. And what I understood, it was difficult for her because it was her mother, is that, you know, it's not a logical disease, you know. She says, well, when am I going to get to Atlantic City? You know, in an hour. When am I going to get to Atlantic City? Oh, all right, that's too long. That's too long. When am I going to get to Atlantic City? Oh, we'll be there in 5 minutes. So you learn, I said, you know, for if you live with someone that has Alzheimer's, the most important words to remember is uh-huh. So when they say, and it could be whatever it is, they're not, if you could say uh-huh, it's hard for them to argue with you about uh-huh. So you need to understand yes, dear are two words that are important.
Yes, dear.
Yes, dear. I agree 110%.
I
You
guess
know,
this is one of the advantages of being part of this group. You know, the mentorship just never ends.
Yeah.
never is. I'm telling you. Well, you know
But
that.
I appreciate your recognizing the balloons. I wasn't sure that they were there. So they've been there since Sunday. We got married on June 8th, 77.
Wow.
That's great.
Congratulations
Beautiful,
again.
That
beautiful.
is great.
Congratulations.
Congratulations. You
Mhm.
know, the thing of it also is that they say longevity, especially with males, occurs more likely to have that longevity if you're married. So it keeps us straight too. It keeps us straight. I know my wife keeps me on the straight and narrow, so that and I need that. So that's a good thing.
You know what's interesting about this conversation is, Dr. Spratt, you said something really profound, is when you take responsibility for how your spouse treats you.
Mm.
That is really profound. You know,
Mm.
it's, I don't even know how to comment on that. It just rings home so true.
Mm-hmm.
But you know, I expanded to not just my wife. You
Yeah,
should take responsibility for how anyone treats you.
right,
Really,
right.
Yeah.
you know, it's easy to blame someone else for their faults. And
Mm-hmm.
then my question is, well, is there something I could have done differently that might have
Right,
resulted in a
right,
different
right.
way of treatment?
Mm-hmm.
Some people say, you know, I've tried everything. I've tried everything. I've tried. Well, I'm not sure you've tried everything in terms of, you know, you beat your head against the wall. So there are things that you could have tried differently that might have resulted in a different
Different,
outcome.
yeah.
And when I explain, they, well, what is it? And I give them an example, and they say, oh, well, maybe. But normally people just react
Mm-hmm.
without necessarily thinking about what their action or reaction is going to do to the other party and how they're going to react to your reaction.
Mm-hmm.
Doctor, why don't you give the audience some examples?
Well, I have one question. How do I respond to a military parade in DC? What did I do to cause that?
Well, I think it's not what you did. I think it's for the people that didn't vote because they didn't think it was going to matter. You know, they're seeing that it matters.
Mm-hmm.
Or the ones who vote that didn't think what happens would happen to them or ring so
That's
close to
correct.
home.
You
Yeah.
know,
Yeah.
yeah,
True,
yeah.
true, true, true. All
Yeah.
right, guys, listen, this is the deal. Dr. James Lee, I would love for you to sum up some, you know what I mean? What do you think we should sum up with? And because we're just about out of time, but I'm so appreciative of you coming on and doing orthopedics because let me tell you, if we live long enough, all of us, every one of us are going to need your services. So, um, just sum up for us.
Sure, sure. So, orthopedic surgery, the study of bone and joints. I think prevention is the key. We have, doctors on this panel that talked about that today. Your healthy living, healthy diet, cutting down on things that will cause inflammation, whether it's trauma, falls, injury, not recovering, not enough sleep, your diet. How can you prevent these things? We mentioned exercise, consideration of supplements, healthy alternatives to what you may be taking, and most importantly, consulting with your physician. Uh, the majority of consultations that I'll see in a day are non-surgical. I mentioned before, and any given day, I see 30 people, 5 are surgical candidates, the other 25 are not. And a lot of times that's education, it's making a diagnosis, and I think there's a degree of peace of mind when people can understand, okay, I have arthritis, well, this is what I should expect over the next 5 years. What can I do to try and mitigate some of these symptoms? And I think a lot of it's just open communication, seeing your doctor, asking questions, and participating in panels like this.
Can I ask you a question real quickly? It might
Sure.
be a long answer. I'm 69 years old and I still work out regularly.
Right.
Um, what kind of program would you think would be more beneficial as we get older, as opposed to like I'm running, pounding the pavement, I'm on a bike, I'm lifting weights? Which one of those components do you think should be maximized and which ones can be minimized?
I would say definitely have some form of resistance training. I think to maintain muscle mass and to bones react to force. So if you're able to create resistance in a safe environment, I think that's critical. You mentioned the cardiac aspect, variety. If you run a lot, I would say maybe consider doing swimming, yoga, other things that can get your heart rate going. Running, those are microtraumatic events. If you run every 5 days a week, then your joints do feel that. And so I would say variety is important, emphasizing some form of resistance training.
Resistance such as bands, weights.
Bands, weights, even something as simple, you take 5 pounds and just do 20 squats. You're working the upper body, you're working your lower body. Maintaining good posture also is very important too. We start to lose our posture, we're not as motivated to want to walk, lungs don't aerate, circulation changes. We want to maintain as healthy a lifestyle as we can.
All right.
Excellent. All righty. Any other questions? Any other thoughts? If not, I'd just like to say thank you to each and every one of you. Just, you know, it's always a pleasure coming on and doing the webinar with you. For the audience, just to let you know that July definitely we doctors will take a vacation month, and most likely it's going to be August as well. So we're going to give the summer off in September. I'm lining up some docs to come on in September, such that we can have some fresh faces. Um, yeah, and we got some great topics coming the months ahead of us. So I'm just excited about it. But give the docs 2 months off here. We're going to take 2 months vacation. We're going to just sit back in a minute, clear our heads, and come back, more excited than ever in September. So we will post that on the web on the web and on the website. I mean, and we'll give you an idea of what's going to come in the future as far as the webinar is concerned. So relax, enjoy the summer. We're out there enjoying it, so we wish the audience enjoys it as well. In closing, I'd like to thank OB Healthy for allowing us to bring this webinar to you. You don't know how much it means to myself and the rest of the doctors to be able to educate our community about health. Um, it's just so important. Just to give you an idea, prior to this, we were down at Metropolitan Church there in Newark, and it's Men's Health Day. They wanted to do that before Father's Day, and there were I'd say about 300, maybe more, black men down there, and we had doctors answering medical questions down there this morning. So it's that type of thing to bring our community together for true health, true knowledge and understanding about their bodies and how to keep it healthy. That's so important to all of us physicians and healthcare workers. Remember, it's always the second Saturday at 1 o'clock. So please tell friends, family about us so we can increase our numbers, because believe me, it takes a village. Caring and sharing, that's what I was talking about, increasing the numbers and letting others know. Please do not change any aspect of your medical care until you consult your physician. Believe me, only your doctor can truly take care of you best from a medical perspective. Alrighty, if you missed our webinar, all you have to do is go onto the website and hit the YouTube sign, and all of the past webinars come up. And just educate yourself. That's what's so important. Other than that, I'm just going to say, everybody have a great summer. We will see you back in September, okay? And yeah, I want to say peace. Let
Peace.
us just enjoy yourselves. Enjoy yourselves throughout the summer, and we're going to come back even better. All right,
All
then.
right.
Take care,
Great.
everyone.
Bye-bye.
Bye-bye.
All right. Patrick, give me a call.
Yes.
All right.